Hello, and welcome to the Duke Cardiology Conference. I'm Sunil V, Assistant Professor of Medicine here at Duke University Medical Center. Thanks for joining us. Today's program is titled Acute Coronary Syndromes Management in Patients with Diabetes Mellitus. And our distinguished guest is Dr. Christopher Granger, Professor of Medicine here at Duke in Durham, North Carolina. Chris, thanks for joining us.
Thanks, Sunil.
So, last week I was rounding in the CCU, and we encountered a patient, a 74-year-old lady with a long history of type 2 diabetes, insulin requiring. She had come in with a non-ST segment elevation acute coronary syndrome. She had had a history of perhaps a TIA about 5 years prior. She's about 68 kilograms. And a lot of our discussion revolved around the types of medical management that we should be instituting before deciding on whether she should undergo invasive risk stratification. The concepts we were thinking about were what antithrombin therapy, what antiplatelet therapy, should we be tightly controlling her glucose? There was some buzz a few years ago about GIK and whether that has a role. What can you tell us about the latest state of the literature in the patient with diabetes?
Well, I'll review all those issues, actually, Sunil, and I think that's a common patient, isn't it? And it's a high-risk patient, and I think that's one of the themes that we'll discuss. First of all, we know that this is an increasing problem, that not only for patients presenting with acute coronary syndromes, but in the population in general, there is this epidemic of diabetes and obesity in the U.S. and in other Western countries. And it's particularly a problem in our part of the country, in the southeast, where we have this alarming increase in the proportion of the population that has diabetes. But even places like California and other parts of the country now have much more diabetes than even a decade ago. We also should remember that diabetes is a condition that is characterized by a variety of other comorbidities in a large proportion of the population. So that when we talk about diabetes, we're talking about a population that has, of course, obesity, hypertension, lipid abnormalities, and renal insufficiency as key comorbidities that we also need to consider when we're treating this population. And in fact, when we look at cardiac biomarkers, or biomarkers in general, that relate to outcome following acute coronary syndrome, where there's been a lot of important research and understanding about how these biomarkers relate to outcome over time following acute coronary syndromes, we see that a number of these biomarkers relate to diabetes or related conditions, including in this review by De Filippi, inflammatory biomarkers, CRP being much more commonly elevated in patients with metabolic abnormalities, accelerated atherosclerosis, and vascular damage, particularly as it's manifested through the kidney, either with decreased renal function or microalbuminuria. So I'll go over some issues with diabetes and acute coronary syndrome. That it's common, it's a potent risk marker. There's a relationship between control of diabetes, or at least blood sugar levels, and outcome. A big question that you alluded to is how should the presence of diabetes modify the treatment that we use in patients with acute coronary syndrome? And then there are a variety of important unanswered questions. So the diabetes prevalence in patients with acute coronary syndrome seems to be increasing over time. If one looks at a variety of clinical trials that are shown on this slide, from Gusto 2B and the TIMI trials through more recent trials, Triton and Plato, or the registries, and you see here a pattern which we commonly see, that is, these comorbidities are more common in registries than they are in clinical trials because we're not so selective in the registries. One sees that somewhere around a quarter of patients, or maybe more in patients with non-ST elevation, ACS, have a diagnosis of diabetes.
Now, Chris, you spend a lot of time rounding in the CCU. Based on your own experience, how commonly do you diagnose diabetes in a patient who, for example, did not know that they had glucose intolerance previously?
Yeah, and that's a great question. And I think the answer is we tend not to make the diagnosis in the CCU, but we should be aware of this issue, and I think vigilant. And I think we tend to be. We have a fairly liberal approach towards getting a diabetes management consult, for example, for patients who have a persistently elevated blood sugar. Part of the issue, though, is that so many of these patients have an elevated blood sugar even in the absence of diagnosis of diabetes in the acute phase of acute coronary syndrome related to stress. And as I'll get to, that also relates to outcome. But should we be using more glucose tolerance testing before patients leave the hospital to come up with a more firm diagnosis of the degree of glucose metabolic abnormality or diabetes that they have? Probably we should be more attentive to these issues. So we know that with respect to outcome that the presence of diabetes is associated with a worse outcome, whether patients have ST elevation or non-ST elevation. This study back from Darren McGuire's work in Gusto 2B. But it's less clear how strongly diabetes is an independent predictor of mortality. There was a nice recent review of a large sample of over 60,000 patients from the TIMI trials with careful statistical analyses showing that diabetes, in fact, was a fairly important independent predictor, about a 1.5-fold increased risk of cardiovascular outcomes and mortality for patients with diabetes in that data set. But when we look at quantitative risk stratification, diabetes doesn't come in as a major factor. For example, in our GRACE risk model, diabetes is not one of the key factors that relates to risk. It is in the TIMI risk score as one of the 3 risk factors for coronary disease that comes into that, but it's a relatively modest impact in the context of other factors. But these relate to diabetes. For example, diabetes is much more common in older populations, so age is a key factor. Killip class, patients with diabetes are more likely to present in heart failure with their acute coronary syndrome and certainly renal insufficiency. And then, as I mentioned, if we look at the relationship of glucose, either at the time of admission or during the early hospital stay looking at fasting glucose, there's a strong relationship with these measures of glucose and outcome following acute coronary syndrome. This is a study published by Peter Sinov from the GRACE registry, and that is independent of whether a patient has an established diagnosis of diabetes, to your point. So if a patient has elevated blood sugar, especially fasting glucose, then regardless of whether or not they have a diagnosis of diabetes, they have an abnormality that relates in a linear way to their subsequent risk of death. That then begs the question, might better control of blood sugar result in better outcome? You also alluded to that in questions about your patient. And in fact, the understanding here, the conventional wisdom, has shifted in a substantial way in the past 5 years. So we had some early studies, most notably the DIGAMI study. That was a small study that took a population of patients with diabetes and randomly assigned them to a intense insulin and then supported by glucose regimen with a target glucose range in the 130 to 200 range. And this, in fact, over a 1-year period was associated with a lower risk of death in the more intensively treated population, including with insulin treatment. So this got people excited about the idea that modulating the metabolic environment with a more intense insulin regimen at least might be associated with better outcome. And the early GIK overview with the small trials evaluating whether glucose, insulin, and potassium might improve outcome following MI suggested that it might. But then, in fact, the large studies, the CREATE and ECLA GIK studies, showed really no benefit at all of the GIK approach. So this made people then less enthusiastic. Now, if we look at the guidelines, this is an example where I think the guideline committees may have kind of jumped the gun a little bit, because they were fairly strong. In fact, a class 1 recommendation that an insulin infusion at normalized blood glucose is recommended for patients, for example, with STEMI in the STEMI guidelines. This is also based on some critical care studies, including one from Leuven, suggesting that in the intensive care unit that insulin use to normalize blood sugar seemed to be associated with better outcomes. And then this was also reflected in the 2007 non-STEMI guidelines, both the ESC and the ACC-AHA as a Class 1 or Class 2A recommendation to have fairly aggressive control of blood sugar in non-ST elevation MI. But then with the newer GIK data, with other studies, with other studies of patients with diabetes in the chronic phase, suggesting that tight glucose control is a double-edged sword, this has been substantially loosened up now. So I think the 2009 STEMI-focused update is relevant probably for all acute coronary syndromes, where the recommendation is that it's reasonable to use an insulin-based strategy to keep the blood sugar less than about 180, but being very sensitive to avoid hypoglycemia.
Is that the thought then, is that some of the lack of benefit or perhaps some of the harm is driven by the hypoglycemia rather than just it just doesn't seem to be working and it's fairly resource intensive?
Yeah, I think that's the sense, Sunil, that it is a double-edged sword, that in some patients there may be a benefit, and presumably there is a benefit in avoiding more pronounced hyperglycemia, which has its complications as well. But tight control of blood sugar, which we hoped might improve outcomes, simply overall doesn't. So you don't have to worry in your patient about tight glucose control, at least in the acute phase. How about this interesting question of should we, when a patient comes in with diabetes, should we label them as a patient with diabetes with important implications for what strategies to use in the management of acute coronary syndromes? And I'm going to argue no, that we should be aware of it, that it's one factor, but it's one of many that relate to the broader issues of what risk is the patient at that might modify treatment selection. As you know, we've got a lot of choices in patients with acute coronary syndromes. If we simply look at the selection of antithrombotic therapy and invasive strategy for anticoagulants, we've got 4 choices that are all Class 1 recommendations in the guidelines. For antiplatelet therapy, aspirin and its dose, clopidogrel and its dose, prasugrel, presumably before long ticagrelor, all choices. IV antiplatelet therapy, none, or abciximab or a small molecule, and the timing. CAS strategy, early, delayed, or never. And this oversimplified set of decisions is 144 different combinations. And then that should be modified, we're told, by the risk that a patient's at of thrombosis, and as you've been a leader in, also the risk of bleeding, and issues about importance of focusing on dosing of these agents. So it's complicated, and we need help in how do we sort this out? How do we decide which treatments to use? With respect to 2B3A inhibitors, there was a sense that diabetes is a state in which the platelet is more activated, and we know that's true. The inflammatory markers are more intense, and that this may be a particularly appealing population to use glycoprotein 2B3A antagonists. And in fact, overviews of the larger trials have suggested that this is a population that may get particular benefit from 2B3A inhibitors. In fact, this was reflected in the 2007 ESC guidelines, where it was recommended that patients with diabetes be treated as an initial part of their treatment strategy with 2B3A inhibitors, as well as an early invasive strategy. Other data, though, including Eric Boersma's overview of the overall 2B3A experience, suggests that maybe diabetes isn't a major modifier of the treatment effect, no statistically significant interaction of the effect of 2B3A inhibitors according to whether or not patients have diabetes. And then in the early ACS trial, likewise, the point estimate was for a little bit more of a benefit with early eptifibatide with diabetes, but no statistically significant interaction. So I think a more appropriate conclusion is diabetes shouldn't be used as a single factor to make decisions about either the timing or the use of 2B3 inhibitors, at least not in isolation.
And that certainly is a change, as you said, from what we all believed about 5 years ago, isn't it? And how much do you think the fact that other treatments have evolved have played a role in that? I mean, we've got more aggressive oral antiplatelet therapies now. Patients perhaps are going to the cath lab a lot faster. Is the fact that those strategies have changed, does that attenuate any benefit of the previous strategies, do you think?
That may be part of it.
Concept flawed?
Yeah, that may be part of it. I think maybe, though, it's the old issue of subgroup analyses, isn't it? Mm-hmm. When we look at subgroups, we see differences, we kind of focus on them, perhaps, and we tend to focus on single risk factors and variables rather than looking at the overall patient. So that's what I'm going to argue is We need to be moving towards a more global risk assessment to make some of these decisions, and that's very important. Yeah. But the single factor of diabetes may be less important. Although there is a theme here. I will suggest that it's not unreasonable to take diabetes status as a factor to make decisions about intensity of antiplatelet therapy. And for example, from the Triton trial, the benefit of prasugrel versus clopidogrel seemed to be particularly notable in the population of patients with diabetes, and the bleeding risk didn't seem to be substantially increased there. And then in a nice manuscript by Steve Wiviat that really went through this in a great deal of detail, you see that patients with diabetes were at higher risk for the various outcomes, including the primary outcomes, CV, death, MI, and stroke, and myocardial infarction itself. And the absolute benefit seemed to be greater there, although the statistical test for interaction was not significant. So this, some people, the purists might argue, therefore ignore it. The practical person, though, might say, we see this pattern pretty consistently. Diabetics are both at higher risk, and more potent antiplatelet therapy seems to have a tendency for a greater relative risk reduction in that population. So I think it's reasonable to consider it, but we probably shouldn't overemphasize it. And then we see in the Plato trial, ticagrelor in the population of patients with diabetes didn't have a tendency for greater treatment effect. So this would go against a little bit the idea that there is this consistent pattern of more potent platelet inhibition and a greater benefit in the population of patients with diabetes. This may be well summarized by this manuscript by Keith Fox that took the trials that randomized patients to a routine invasive versus a selective invasive strategy with acute coronary syndrome and did an individual patient-based meta-analysis. And then did a variety of analyses, including looking at what are the risk factors that predict outcome, in this case of death and MI. And diabetes, interestingly, was the second most important predictor of risk. So it's a very important predictor, independent predictor of risk in this population looking at 5-year outcome following acute coronary syndrome. And then you see a pattern that's not surprising, that it's the highest risk population that got the greatest absolute benefit from the use of an early invasive strategy. So this argues that the diabetes should be taken into account when deciding how aggressive to be with an early invasive strategy, but that it's one factor in many. And
so
I think it's a nice concept.
So it's reasonable to say that certainly we should take into account diabetes, but in the absence of diabetes, but the presence of other high-risk factors, that's a group of patients that also should perhaps be treated more aggressively. Is that fair to say? I
think that's fair to say. And in fact, and those factors here were age was the most important factor, prior MI, ST depression, were some of the important factors. So that's the theme, I think, Sunil. Now how about unanswered questions and other interesting areas around diabetes and metabolic abnormalities in acute coronary syndromes? Some of the questions, I think, are what should our target be for blood sugar control? Is it less than 180 or less than 150? And are different strategies maybe more effective? Because we know diabetes is a strong risk factor, as is glucose elevation. So it seems like still an important target to be investigating. Is more intense platelet inhibition particularly beneficial in this population? Is still, I think, an area of open debate. Probably yes. And might novel metabolic modulating agents be beneficial in this setting? And one of the nice things that we now have is the FDA mandate to be studying new drugs for diabetes for cardiovascular outcomes. And many now are studying patients with acute coronary syndromes as a mechanism to test the cardiovascular safety and effect of new agents for diabetes. Now, another interesting compound with this regard is ranolazine. So in the Merlin trial, 6,500 patients with moderate to high-risk acute coronary syndrome randomized to ranolazine or placebo. Overall, no significant effect, slightly lower risk of the outcome in patients treated with ranolazine. And as one commonly sees, generally the higher risk patients, either the elderly or diabetics or high TIMI risk score, or patients with ST depression, had a tendency for a greater relative risk reduction, although none of these was a statistically significant interaction. But then there was this interesting other feature with respect to diabetes and metabolic effects that was seen in some of the earlier trials with ranolazine, but really I think more nailed down in the Merlin trial, where for either patients with diabetes or patients without diabetes, there was this reduction in hemoglobin A1C during the first year or so for patients with diabetes, and at the end of the trial for patients without diabetes, an improvement in hemoglobin A1C. And also with this tendency for a greater risk reduction, or not a greater risk reduction, because overall there was no significant risk reduction, but the appearance of perhaps a benefit in patients with diabetes, although again, not statistically significant. It's unknown how this agent that inhibits the inward sodium channel and therefore has this effect on reducing recurrent ischemia might have this metabolic benefit. It could be through effects on the pancreas, but it's an interesting observation in the Merlin trial. So I'll just summarize then that diabetes is common in acute coronary syndromes, that diabetes and hyperglycemia are associated with worse outcome, some of that related to the comorbidities and other features of this population, that strict control of glucose has not been shown to improve outcome, either in the acute or the chronic setting, and so we're much less focused on that than a few years ago. Diabetes is a risk factor, and the absolute benefit is therefore greater in diabetic populations for most of these effective therapies, but diabetes alone isn't what we should focus on. I think we should be focusing on global risk. And some of these specific therapies, including DPP-4 inhibitors and acarbose and PPAR, dual PPAR inhibitors, and other drugs are being studied in the ACS population of patients with diabetes to see if some of these specific approaches may be beneficial in this high-risk population.
That's fascinating data, and I think one thing I want to get your thoughts on is one of the points that you made here, where diabetes is a risk factor, but you've been a big proponent of risk scores, and specifically the GRACE risk score, which I think performs probably the best out of any of the published ones, for risk assessment when patients come in with acute coronary syndromes. The guidelines have come out in favor of that. What do you think, in your estimation, has been the barrier for adoption of this in at least U.S. practice? I mean, we tend to dichotomize, right? Diabetic, not diabetic, old, not old. Why is it that we're not more facile at using these risk scores?
I think there are two main reasons, Sunil. One is that for these to be used in practice, they have to be more practical. And this is an advantage of the TIMI risk score, is that it is easier to apply. But I think the way to make them more practical is to have them integrated in information systems. For example, now in our emergency department at Duke, every patient gets a TIMI and a GRACE risk score as part of their intake, because it gets entered into the computer and therefore gets generated. And I think that's what we need. We need something that's simple and more practical to help us, because we all risk stratify. And in fact, there was a nice study by Sean Goodman showing that when you ask an experienced cardiologist, what's the risk of this patient, and you do a quantitative risk score, there's a systematic error amongst the practitioners. And one of the reasons is they seem to incorporate the importance of age in as they stratify risk. But I think we need the quantitative risk. The other issue is that when we do these risk scores, they're a snapshot in a patient that has an evolving risk over time. And that's another thing that's frustrating, I think, as a clinician. Maybe it's helpful at the time the patient hits the emergency department, but by the next morning when we're making some of the decisions, the patient's been cath, they've had a bleeding episode, they've developed some heart failure, and their risk is very different than when they came in, so we're not going to depend on that baseline risk score anymore as we think about that patient.
Now, in that context, when we're talking about the diabetic patient, one thing that we all experience, at least anecdotally, is that by the time these patients present to us, they often have, at least it seems that they have more advanced coronary disease. Is there any truth to that?
Yeah, I think there is. There are a variety of studies that have shown that so this gets into the intervention area, which I didn't really touch on, and choice of stents and choice of drugs during intervention. And I think that is true, that the conventional wisdom that patients with diabetes have more diffuse small vessel disease.
Mm-hmm. And in that context then, again, talking about the diabetic patient and their risk of events, do we have any information about whether it's more common for them to present with non-ST segment elevation ACS versus ST elevation?
The ACTION registry data suggested at least that for patients with non-ST elevation ACS that the larger proportion of them are made up of patients with diabetes. So that would suggest, I think, as you are saying, that the patients with diabetes are a bit more likely to have non-ST ACS.
And that may, in fact, explain some of the worst outcomes in that patient population. Now, getting down to sort of brass tacks about the way you approach a patient with diabetes in the CCU, talk a little bit about the strategies that we're implementing here at Duke to treat patients with ACS. What does our pathway say in terms of antithrombin therapy, antiplatelet therapy, how diabetes may or may not play a role in that selection process?
So our algorithm, Sunil, which you've been helpful in developing, actually doesn't take diabetes itself into account to make decisions. And so what our algorithm does is basically take patients and put them into either a moderate or high risk category or a low risk category. And if they're moderate or high risk, then generally apply a standardized approach that includes an early invasive strategy. We've generally now limited the use of prasugrel to patients with STEMI and to patients who have failed, who've had stent thrombosis on clopidogrel. For example, your patient, by the way, getting back to your original patient who had this possible history of TIA, 74-year-old woman, low body weight, is somebody who you'd love to use a more potent platelet inhibitor because she's at high risk, but we'd want to avoid using prasugrel because of the risk of intracranial hemorrhage in that patient. So I think the important thing is to try to have somewhat of a standardized approach in each hospital, so that people know and can systematically apply treatments and improve communication and coordination.
What has been the evolution of the way we're using 2B3A inhibitors now in the acute setting?
Well, because we've been very involved, Kristen, co-leading early ACS and involved in a lot of the development of 2B3A inhibitors, we still use, as you know, a lot of 2B3A inhibitors in the lab. We're using more bivalirudin, which I think is appropriate, including in the STEMI setting, where Horizons had such impressive data. But we're using very little 2B3A inhibitors up front, only for patients with refractory ischemia.
Now, one thing that you mentioned, which I found very fascinating, is that it seems like as we're going forward with clinical trials, a lot of the studies are using diabetes as an enrichment factor for increasing the risk of these patients to determine if some of these therapies are going to be effective. But you also mentioned that a lot of new diabetes drugs are using ACS development as a safety signal. Talk at a high level about why that's been an issue with diabetes treatments.
Well, as you know, historically, the way diabetic drugs have been developed for glucose control is to simply show that there's an improvement in blood sugar, and then we've seen that some of those drugs may have at least an uncertain safety profile with respect to the most important outcomes for these patients with type 2 diabetes, which is cardiovascular outcomes. And of course, we have all the rosiglitazone experience, where I think there's still uncertainty about what the effect is, but at least there are major questions that really call for us much earlier in drug development to have an established safety profile with respect to cardiovascular outcomes.
So it looks like we've got a lot to look forward to then over the next few years with respect to diabetes and its treatment. My guest faculty today has been Chris Granger, one of my colleagues here at Duke. Chris, thanks again for such a great presentation and for taking time with us. Until next time then, from all of us here at Duke, this is Sunil V saying thanks for joining us and take care.